The broadcast is now starting. All attendees are in listen-only mode.
Good morning. Hi, my name is Dr. David Lechner. I'm the Chief Medical Officer here at Community Medical Center. We are excited to have our Friday morning speaker here this morning. This is sponsored by Western Montana AHEC, as you may recall. This is Dr. Josh Christensen, who's an infectious disease physician who works primarily at St. Pat's, originally from Montana, did all of his undergraduate as a bachelor's in microbiology and medical technology at the University of Montana. His MD degree was internal medicine residency and ID fellowship was at University of Colorado. He's been at St. Pat's now since 2010 as an infectious disease and a hospitalist. So we're pleased to greet you over here, and we're excited to hear what you've got to say. Thanks, Dr. Christian.
So I'm Josh Christensen, and as he said, I'm an ID doc and a hospitalist through St. Pat's. I have an interest in zoonotic infections. I grew up on a cattle ranch, and we had cattle and we had warbles, and they'd get various infections. We'd worry about vaccinating for bangs, stuff like that. So it wasn't much of a stretch to go into microbiology and then into infectious diseases. It turns out zoonotic infections, and I'll get to definitions here in a minute, but they're very common, a lot more so than we think, and part of it has to do with there's a perception that they're all these strange exotic diseases like brucellosis or glanders, and actually there are a lot of common ones too. I've had personal experience with more than, well, at least one that I'm 100% sure of, and probably some others, meaning I was infected with them, and I recovered. Most people do. In any case, so I'm going to start walking through them. This picture here is a mountain goat skull that my wife and I found while we were backpacking the Wind Rivers, and I just had to throw that in. Let's see. I apologize up front. I did all my slides on a Mac, and the compatibility with my Mac and then PCs is a little dicey. So last night I edited out a few misspellings, and it turns out this version they're not edited out. So there's going to be a few, and please don't laugh too hard or mock me. So the definitions I'll go through real quick. What I tried to do in this talk, based on feedback from past talks I've done, is try to make it a little more general and reference easily defined references like NIH, World Health Organization, rather than just obscure PubMed articles, which are what we typically reference on, or which I shouldn't say typically, which I used to reference on talks, but I tried to make it a little more of a broader interest and easier for people to fact check me. So start with definitions. So what are vector-borne diseases? And this is right from the NIH's website, and they define them as vector-borne diseases such as malaria or those in which an organism, typically insects, ticks, or mites, carry a pathogen from one host to another, generally with increased harmfulness of the pathogen in the vector. And then they further define zoonosis, which includes avian flu, diseases that can be transmitted by animals to humans by contact with animals or through the vectors. So it turns out that there are actually a lot of these, hundreds of them that we know of, and I'm sure there are probably hundreds that we don't know of that we're hopefully going to eventually figure out. Some are everywhere, worldwide, and some are very regional. And they consist of all sorts of different diseases, viruses, bacteria, protozoans, helminths, which are worms, funguses, and arthropods. Lice are, in their own sense, a zoonotic infection. If you're infested with them, you're infected with lice. So that's one I've had. Most of us at some point have been a host to a zoonotic disease of one kind or another. I'm going to go over initially a fairly wide list of zoonotic infections, briefly, just to give you an idea of the scope of them. And then I'll go through a few in more detail that I've seen through my practice here in Missoula. So we'll start with the arthropod-borne viruses, which are arboviruses. And it's very clever. It's arthropod-borne, ARBO viruses. So some genius came up with that term. Hope I didn't offend somebody somewhere. Any case, there are different genus of the viruses. There's a Togaviridae, Satogaviruses, which are Eastern or Western equine encephalitis. That's one of my typos. And chikungunya. So these are the Togaviruses. They're the flaviviruses, which we hear a lot about. Dengue, West Nile, Powassan, Zika, which gets a lot of interest lately. Yellow fever, for example. The Bunya viruses, lacrosse encephalitis, and the Rhea viruses, which is Colorado tick fever, which we have Colorado tick fever here. We have West Nile here. We get some of the encephalitis intermittently. And then there are the bacteria, which I'm a little more interested in, mostly because my background in microbiology at the time that I was a microbiology undergraduate. The viruses probably weren't as well known or weren't as well studied where I was doing my undergraduate, so there was a lot more information on bacteria. And when I was a fellow, I mostly worked with bacteria. I haven't done a lot with viruses, so I'm not by any means an expert in virology. I have an understanding of clinical presentation and treatment for it, which for most of them there isn't much you can do, at least at this point in time. But anyway, these are some that we'll tend to see: ehrlichiosis, Lyme disease, relapsing fever, which we have up the Bitterroot. Rocky Mountain spotted fever, which every summer we get a handful of cases. And to be honest, most of these never come to the ID group because the emergency department and primary care docs are so good about picking these up. A lot of them, you don't even send the serology because the turnaround time's so long. By the time you get your result back, you've already treated them for it and they're better. So a lot of patients are just treated on their presentation and they do just fine. Tularemia, which we have here. Typhus, which we don't, thank goodness. Murine and scrub typhus are a little bit more of a warm area. Epidemic is the one that killed a lot of people in World War I, and you see it in areas of conflict and where you cluster people together. Q fever we pick up a case or two a year, maybe. Well, maybe not quite that much. We had a Q fever endocarditis we treated a few years ago in Anaconda. And then there are the parasites, which they're fascinating, and they run all the way from the babesiosis, which is an East Coast organism, Chagas in South America, Leishmaniasis, which is worldwide, and malaria, which is also worldwide. Turns out malaria was a big killer of people in the 1700s in the United States. It was all over the eastern seaboard, not there so much anymore, the southern part of the eastern seaboard. And then there are the ectoparasites, which I have a kind of a personal liking of having seen bots on animals, and I have a bunch of pickled warbles from when I was a kid. Some of them are, an inch or two long, great big fat bots we'd extract from cattle. Tungiasis, which is sort of another, it falls under myiasis. It's another, basically a maggot that infests humans. Scabies, lice, and then fleas are some of the ectoparasites. I've had fleas too, I guess. I've had probably a lot more of these than I'd care to admit. Well, how do you get them? These are the ones that you get from ingestion, skin exposure, and inhalation, the bacteria. Anthrax, which everyone's heard of, Bartonella, cat scratch disease is the one that we see every now and then around here. Brucellosis, pick up the odd case. Campylobacter is incredibly common. It's ingestion and it's a zoonotic infection because it's associated with poultry primarily. But you can see it with poorly handled or processed meat, and a lot of it's just bad luck. They could do everything right at the slaughterhouse or the poultry processing plant. You can still get it. Glanders, which is a disease of horses that infects humans. Some of these are also interesting in that they're what we call select agents, meaning they can be weaponized. So anthrax can be weaponized. This one can be weaponized. I have a little bit of experience with that. When I was a fellow, we played with the agent of glanders and some analogs of it, and we were scrutinized, of course, at the lab I worked in by NIH and CDC to make sure we did it correctly, and we had isolation containment, nothing like they do at Rocky Mountain Lab, but we still had protocols we had to follow. Leptospirosis we pick up, listeriosis, pasteurellosis, we'll see that, plague. Cases of that from time to time. Not so much in Montana, probably a few, but more, Colorado, Utah area. psittacosis, which is picked up from birds. We pick up that once in a while. Rat bite fever. I treated a kid for that a while back from his pet rat. Salmonellosis, which is pretty common, and tularemia, which we see. I'm not going to present a fun case in the salmonellosis we had, but I'll briefly go through it. We had a patient that had 2 recurrent admissions with bacteremia with salmonella, and it turns out she had a pet reptile that she would kiss and cuddle, and that we think was a vector. We strongly encourage her to let someone else adopt it. She was an immunocompromised patient, and I suspect that might have happened, or she got better with how she handled the animal, because we haven't seen her in a couple of years. So, and then there are the fungi, and this I actually did pull a slightly obscure article on, because some of these we don't think of as being zoonotic. So direct contact or microsporum, sporotrichosis. This one, in all the board questions, it's somebody sticking their finger on a rose. But it turns out it's on the skin of animals. And if you have a cut and you're petting your animal, your dog, what have you, you could theoretically get it, and trichophytons as well. Part of the reason why is these are organisms that are found in the dirt, and most animals are in the dirt. And then the inhalation of the fungus. We see this every year. I get some cases of coccidiomycosis, which is valley fever. We get people that are snowbirds or down in Utah, Arizona, inhale the spores, they come up with a pulmonary nodule or an acute respiratory illness. And every year we pick up cases, and some are pretty straightforward, some of them aren't. And they're satisfying in that I'd say maybe once a year or so I get somebody sent to me that was sure they had lung cancer. They had a pulmonary nodule, it was getting bigger. Then someone noticed it, and there was a biopsy done, and I'll be darned, they have this, and this we can get rid of. And a lot of times you don't need to do anything. So they're really pleased. You usually don't see people happy to have a parasitic, well, not a parasitic, but a zoonotic infection, and they are, and I would be too. Cryptococcus we pick up, different forms of it, sometimes in immunocompromised patients, but occasionally it can present really dramatically in healthy people. And then paracoccidioides and pneumocystis, which is primarily a disease of patients with advanced HIV, but now that we're getting better and better at treating people with malignancies, we'll see it in cancer patients who are on significant immunosuppression with steroids. And it's not one that I had really thought of as a zoonotic organism until recently. I was reading some papers, well, not super recently, but last couple of years, and all these make the list of zoonotic infections now. And they do a good job of arguing why. They're associated with animals. And then there are the viruses, Ebola, of course, hantavirus, which we see cases every year. And I was going to present a couple of cases of this, but one of my colleagues has some interest. We've kind of got a running tally of patients with it, and they might want to use it down the road. So I'm going to leave that one alone. We see that, though. And some patients die from it. It can be a fatal illness, and some recover. And it's always sort of an exciting diagnosis to make. Obviously you don't want your patients to have it, but you want to know what it is when they're sick. Influenza, which people get from animals to some extent. I mean, that's, you think about they talk about swine flu and bird flu, etc. This one is an interesting one, lymphocytic choriomeningitis. It's not common around here, but it's associated with rodents, and it can be a pretty severe illness. Marburg, which sort of falls underneath the ones of Ebola, viral hemorrhagic fever, monkeypox. George Reese, who used to work here, he would vaccinate some of the workers at Rocky Mountain Lab because they work with this agent. So we would use smallpox vaccine, which is really vaccinia. And we had some of this in the office for a while, and I waffled on secretly vaccinating myself, and I thought ultimately I probably better not, because we had to destroy the vaccine if we weren't going to use it. Orf is a fun one associated with sheep. It usually doesn't make people very sick, but they'll get a big, what looks like a herpetic whitlow, a big blister on their hands where they're handling the sheep. Rabies, of course, and then vaccinia, which is cowpox. I've seen cases of a few of these, well, influenza, many cases of this, and then hantavirus from time to time. Many of these I haven't seen, and to some, like rabies, while it would be intellectually satisfying to see them, I hope I never do, because by the time they present, they're going to die. So, and then on to some of the protozoans. These are amoebiasis. Most people around, well, I shouldn't say most, many people will get an amoebic infection of some kind over the course of their life. Giardia is common around here. It was in the Peaburg water supply briefly, and my mom got it. Whether or not she got it from the water there, I don't know, but we had well water. Maybe she got it from our water. Maybe she got it from where she was drinking water in town. Toxoplasmosis we see quite a bit of in HIV patients. It can present pretty dramatically with huge brain lesions. But it turns out it can present with just a febrile illness, febrile illness and big lymph nodes in healthy people. And we treat a couple cases a year of toxoplasmosis. The diagnosis is in healthy people is a little tricky to make. You do it on serology, and you're never 100% sure you made the diagnosis, but you're usually pretty confident you treat patients, and they get better. And their serology will show, you'll have your acute and convalescent serology. So we presume we made the right diagnosis, and they get better. And then the old coccidioices, which probably everyone who follows medicine at all notes that we're always changing the names of these. So what used to be the coccidioices are now typically these, and the cystisospora used to be isospora when I was in training, and we had mnemonics to remember these, and now those are no good anymore. But anyway, cryptosporidium I've had the most terrible diarrhea in my life for about 10 days, and two of us got it, and we'd both eaten cherry tomatoes from the same place, and that was the only connection. And one of us got tested, and then one of us didn't, and we both had the same illness. It ran its course. We were fine. But I lost about 10 pounds in about 2 weeks. It's a good way to lose weight, but boy, is it miserable. You don't get more than about 50 feet from the bathroom. And then there are the helminths. Draconoliasis is one that has gotten a lot of press because it's theoretically able to be eradicated, or at least that's what we thought. And there was a lot of effort by World Health Organization and some big philanthropists pushing to treat it. I think it was something Jimmy Carter was interested in helping eradicate too. But it turns out recently it's in dogs. So you've got feral dogs in areas of Africa. The ability to treat all the dogs is a lot harder than treating people. So you've got a reservoir of it. That's going to make it harder. Echinococcus, it's worldwide. There are different types of it, but it's primarily the more common one is associated with sheep. And the cases I've seen have been people that have lived in the Mediterranean area, the Middle East, and this is one that there's a big reluctance on the part of radiologists to sample liver cysts that might be this, because there is a small risk, but a potentially horrible one, of people having anaphylaxis when you puncture the cyst. And I actually saw a case of that when I was in training, of someone who had anaphylaxis, and they ended up anoxic brain injury and were severely disabled the rest of their life. And there was a huge settlement, and understandably people are cautious about puncturing those if there's a high index of suspicion. Luckily, it's pretty uncommon around here, and there is a form of it that you see in foxes and coyotes, and interestingly, for whatever reason, mostly Arctic foxes, so it's more of a disease in Alaska and Canada that has a propensity for lung instead of liver. Hookworms, which are incredibly common, ocular larva migrans, which is a worm in the eye, which is an exciting thing to see, and it's fixable, so it's dramatic and fixable. It's one of my favorite. That's sort of my favorite combination of infectious disease, something that is dramatic and fascinating, and you can cure. Everyone's happy at the end then. Schistosomiasis, which we think of as an illness of, say, Egypt at the Aswan High Dam or something, but swimmer's itch is a schistosomiasis, which is a bird one. You go out in the water, and we're not the right host for it. It gets in our skin and it dies, and it itches to beat the dickens, and it goes away. And then the toniasis and cysticercosis, which are, we do run across these, where people get these little parasites encysted in muscle. So I'm going to go over some select cases seen here in Missoula. These are ones that have been treated in our office. This I ripped off of our website from a case we actually had. And this is Janet Newman. She's one of our nurses in the office, and probably the best nurse I've ever worked with. I really am always impressed by her. I think this is around the time I had a new baby. Look at the bags under my eyes. So I'll start with the first case here. This one is a returning traveler case, which a lot of these are, but not all of them. 67-year-old woman. She's a world traveler, very experienced in traveling to areas throughout the world. And here's a list of some she'd been to in the last 5 years. And the list was quite a bit longer. This time of the year, I kind of get depressed thinking of all these tropical places, and I'm out here in the snowbank. But past medical history of several chronic illnesses, all that were well controlled. She traveled to Bonaire in the Caribbean in January, and she recalls a few mosquito bites, but nothing excessive, just sort of the annoying mosquitoes, a few bites. And she had been vaccinated for yellow fever at some point in her many travels. So she returns to Montana, and she gets a high fever. And she's a woman who's traveled a lot and pretty canny and calm. And she said, "Well, I'll wait it out. You know, this happens." And she ended up with this diffuse rash, red rash, and it itched. She was very fatigued, and her eyes were very irritated. She describes this Satan eyes. I think that might even be the term, or devil's eyes or something, just these very red, irritated eyes. And they gradually got better, and she was able to continue, with her life and her work and so forth, and didn't get too worked up over it. But then she had the rash come back, and it was more mild this time, but it came back. And then she understandably said, we need to figure this out. This is something I don't want to have keep coming up. So initial workup, and most of it, to be honest, was done by a rheumatologist. We were just mostly asked to see her to figure out what to do with these results. So she came to see us in the office, and by the time she came to see us, there was really no rash to see, so I couldn't get a good photograph, no devil's eyes or anything like that. Just a woman who could give an excellent history of what had happened and some labs we had. And as they like to do, I don't know why I still do this, it was beaten into me in training. You say a diagnostic test was performed, so I think it's a filler you put in your slides. You'll see that a lot. It was consistent with and I put flavivirus, actually an arborvirus infection, because there are some that are not flavivirus that are on my list here. That was a typo that I fixed in my MAC form, but not in this one, unfortunately. Anyway, serology got sent for stuff that fit where exposure was. And the results came back. It was negative. Her IgG and IgM were negative for chikungunya. The West Nile IgG was positive. IgM was negative. The dengue IgG was positive and IgM was negative. And the Zika IgM was negative. And what the IgM is sort of the acute antibody in most cases. When you initially get sick with something, your body makes an IgM. And over time that wanes. And as that's waning, your body makes a memory antibody, which is the IgG. Then in most cases, you have the rest of your life. Her Zika IgM was initially negative. But this was right when we were having all the excitement with Zika, and the CDC wanted to know, the state wanted to know, and she was in a place that had Zika. So a little more testing was done, and it turns out that with these confirmatory tests, we found more. And this is actually a cut and paste of what these labs look like when you get the report. And the CDC actually apparently contracts with the California Department of Health. So we sent our tests to the state, and the state then sent them to the CDC, but I think rather than going to the CDC and then back to California, they were sent from the state of California. But in any case, this is what the reports look like when you get them. And this is a plaque reduction neutralization test, which is a sort of a more advanced testing to look for evidence of exposure to the virus. And I'll be darned, Zika and dengue were positive. And it turns out her Zika IgM was presumptive positive. So she did have Zika. And that fits with the recurrent rash, and that fits with the eye itching, and that fits with the itchy rash. A lot of viral illnesses, a lot of the arboviruses will cause rashes and fevers, and the eyes and the itching are more common with Zika, but it doesn't mean it had to be. You can see them with the others. And the whole story with Zika is still evolving. It turns out in many people, you don't even know you have it, or you just get mildly sick, have a little bit of rash. But in some people, they can get really sick, and it's particularly of importance in pregnant women. We're starting to find out there are more and more fetal abnormalities associated with it. But she had Zika and she had dengue. So as far as Zika goes, it's widespread now. It's basically worldwide in warm areas, and we have in the United States now. I believe it's Texas and Florida area, and who knows? It might eventually come up here. Probably not due to the mosquitoes, but it may. It may. 80 species, there are different species that carry it. It's also sexually transmitted. well documented now, maternal fetal, blood transfusions, and organ transplant. And then there are these intriguing non-sexual close contact where family members, intimate family members of people that live together would get them, but they're not sexual partners, they're not sharing razors or anything. We think maybe urine or sweat is a way you might be able to get it. And again, most people are asymptomatic. Fevers, rash that is often itchy, joint pain is common, and the eye. So if you have a patient that's been in the Caribbean and they've got very irritated red eyes and a rash and a fever, you can think about Zika. At this point, it's just supportive treatment. There's not much that we can do about it otherwise. And she got over it and she's doing great. The other one was the dengue. It's another virus that many who are exposed are asymptomatic. There are three phases to it of people that get sick. There's what we call the febrile phase, where people have a fever, headache, they'll throw up. Sometimes they'll get a rash. And then the critical phase, which is where if this is a severe one, this is where people die. And it can be a fatal infection. They'll have bleeding and shock and multi-organ failure. And when I was down in Colorado, one of the postdocs I worked with, he and his wife went to Vietnam, and he almost died there from dengue, and he ended up in a hospital in Vietnam. And he said he met a Frenchman that everyone called the infectologist. So I presume that's my specialty. I don't know if I want to be called an infectologist. Sounds like you spread it. But anyway, he recovered. And here's the other thing. When you convalesce, you may get another rash. So that might have been the dengue we saw with the recurrent rash. The reason we chased these, part of it was we wanted to know, have a better understanding of Zika, so the CDC was interested in knowing. And it's important to know if someone had dengue before, because if you've had it once and you're infected with another strain, it's usually a lot more severe. So this is a patient that, I said, if you love to travel, continue to travel, but you need to be very proactive about mosquito repellent and whatever tools you can find to not get bit by mosquitoes again in these areas, because if you get dengue and it's a different strain, it could be a lot more dramatic and maybe even fatal. So now I'll move on to ticks, and this is sort of a personal favorite of mine, are tick-borne illnesses. We've got a lot of ticks in Montana, and I think it was 2 years ago I was hiking, and over the course of the day I pulled 9 wood ticks off myself just in one day. When I was in the Navy in Virginia at the Air Station at Norfolk Air Base, Norfolk Naval Station, we'd go walk on the air base, or I'd go jog out there, and I'd find ticks on my legs too. If you're out in the woods, you're going to get them. So these are 2 different cases, and I tried to run them side by side to sort of compare them. 43-year-old woman, depression, drinks too much, has intermittent inflammatory arthritis, and her presentation was always a little tricky because she was sort of non-compliant, but had these just inflammatory arthritis, these migrating joint pains, and they'd be very very painful, almost debilitating for her. And she had been treated by rheumatologists, and they'd made a diagnosis of a seronegative rheumatoid arthritis, which she may have had on top of what I'm going to get to. We still aren't sure. She's still having joint pain, last I heard. So she was treated with various types of immunosuppression, and she'd get better, and then she'd get worse. It'd flare up another joint, and ultimately she underwent an aspiration of the right knee. Now, she grew up on the East Coast, and every summer she'd fly back to the East Coast and be with her family there and spend weeks at a time. And she was an avid outdoorsman. She likes to hike and backpack, and so she was in areas that have Lyme and other tick-borne illnesses. And of course, she lived here, and she was outdoorsy here. So that's her, and I'll go on a little further with her in a minute. The other one is a 55-year-old healthy male who lived in the Bitterroot Valley, and again, this is my typo. It should be a little R, but anyway, he had a fascinating job, and apparently, if you work for the scientific research stations, American research stations in Antarctica, you can make enough through the winter if you work there that you can kind of hang out the rest of summer. So our winter, he would go to Antarctica. It was their summer, and he would work on these research stations. And he said it was, pretty brutal work. You're working 12, 14, 16 hours a day. You basically work and sleep, and you do this for 3 or 4 months, and you make enough money that you can come home. And then he would always travel on the way home, and he would go to New Zealand or he'd go to Australia or New Guinea. So he had this huge travel history. So he presented to Marcus Daly Hospital in July with an acute febrile illness. And I think he came in the first time, and he had a fever, but he otherwise wasn't ill. His labs were pretty unremarkable, and they thought, well, maybe this is a viral fever of some kind. And he traveled all over, but he looked good, so he was discharged from the ED, saying follow up with your doc. And he was fine with that. He didn't feel that sick, but he came back a day or two later, and he was a lot sicker. High fevers, hypotensive, tachycardic, lactic acidosis, all the things we think of with sepsis. He had his liver enzymes were elevated, his chest x-ray had diffuse pulmonary infiltrates, and his right eye was glowing bright red. So he was pretty sick, and one of the lab techs, they were looking at a peripheral smear. He also had low platelets, and they saw an organism on just a smear looking at platelets, and which is a great catch. That tech really did a good job. They had no reason to think they would find an organism on the smear, but sure enough, they did. In any case, so they already had a working diagnosis when they sent them to us. In any case, the diagnostic tests were performed. Well, Our Lady with the knee, they did a PCR of the fluid, and it was positive for Borrelia burgdorferi, so Lyme, PCR of the knee. And she had the serology also consistent with it. And Lyme disease is an illness that, and this will get me in trouble with local people who think we've got it in Montana. We see it a lot in Montana, but it's not contracted in Montana, at least not yet. There's been no conclusive proof that we have the organism endemic in Montana, but absolutely we see it because most other states have it. West Coast, East Coast, South, I mean, there are a handful of states that don't, and we're one of the few. And maybe someday they'll diagnose it here and confirm that it's here, but so far we don't have the right combination of vectors and the pathogen in our state. In any case, but she'd been in the right places. So the diagnosis of this on serology, first of all, you get your initial antibody. If it's negative, you're done. If it's positive, then you do a Western blot because it's not that great of a test. There are a lot of cross-reactivity with other spirochetes, including some that are oral flora, interestingly enough. So there are a certain number of bands, and the CDC has made criteria that if you hit 5 of these bands, you have a diagnosis, a reasonably good diagnosis, and she got practically all of them. So that's her. She has a diagnosis of Lyme arthritis. Our other patient, here is a peripheral smear, and this we published in a paper in 2015, and these 2 images are not from that paper. I didn't want to violate anyone's copyright, but these are some images that we had. This is part of the original smear. This is what the tech saw. There's our spirochete, red blood cell. There it is, and he saw it. Great. I mean, that's a great catch because it's tiny. And then this is an immunofluorescence stain, and sure enough, there they are. And it was confirmed as Borrelia hermsii, which is relapsing fever. So this paper we wrote, it was with Tom Swan's group up at Rocky Mountain Lab. They went to this guy's house, and they set traps in his woodpile, live catch traps, and they caught chipmunks that had it. And they found the ticks there. So, and he gave a great history of when I got back from New Zealand, I was at home and I moved my woodpile. And that's how he was exposed to the ticks for it. So I'll go back to our 2 patients again. Our 44-year-old lady had Lyme arthritis, and this is the causative agent, Borrelia burgdorferi. She acquired it in the East Coast somewhere at some point. We're not sure when. She did not recall rashes. She said, sure, I get bit by ticks. Everyone does when you're out hiking. We treat her with 4 weeks of doxycycline. And when someone has Lyme arthritis, there are treatment guidelines on this. The Infectious Disease Society of America has this huge document on it. And one option is 4 weeks of doxycycline for Lyme arthritis. The other one is intravenous ceftriaxone. And she initially didn't really want to put in a pick and do the IVs, which is reasonable. So we treat her with 4 weeks of oral doxycycline. And that episode got better, but she's still having joint pain. And this is where Lyme gets murkier, is that there is a lot of interest in something that some people call chronic Lyme disease, which some people interpret as it's a chronic infection that hasn't been eradicated. And there are practitioners that will put people on 2, 3, 4 years of IV antibiotics. They'll throw in Flagyl because there's a belief that maybe it's an anaerobe. There are all these cocktails that are used that are not evidence-based. And what's thought is that Lyme in some patients will cause a sort of an immune reaction that then from there on they'll still be ill. I'm not saying they're not sick, but treating them endlessly doesn't do any good, and that's been studied. They've tried retreating people, and their clinical trials, it just didn't work. So there's no evidence for treating with these extensive rounds of antibiotics. Now, whether or not they're ill from it, they very well could be, and they may have a prolonged illness from it, but retreating them doesn't seem to help. You can, if someone fails therapy, you can retreat them. If she failed therapy with that same joint, we could have considered 4 weeks of IV ceftriaxone or something like that. But these endless rounds of antibiotics, there's no evidence to do that. The vector is a black-legged tick. It's also called the deer tick. It's a little hard tick. The nymph that spreads these is about the size of a sesame seed, not a sesame seed, a poppy seed. They're tiny. So a lot of people can get bit. They're not going to see this tick. And some people get the bullseye rash, but some people don't. So it's a tricky diagnosis to make sometimes, and it's an infection that in some people can be severe. It can cause carditis, where they'll have conduction abnormalities. And there's a patient I saw that actually had a pacemaker placed because of heart block. It turns out if you cure the infection, that goes away. So he probably didn't need the pacemaker, but it's hard when someone comes into your hospital with a heart block to not do something. And are you going to leave them in the hospital for several weeks while you treat with IV antibiotics to figure out, is it Lyme causing the carditis, or are you just going to put in a device? So I don't fault anyone for doing it. And he's got his device, and he said, leave it in there. I don't want to fool with it. He thought maybe when the battery went dead, he'd just not have the battery changed. That was maybe as far as he go. But in any case, it's a fascinating disease, and I think that we just don't know enough about it. But the evidence is pretty clear. There's no reason to put people on years of antibiotics. There's just no data for it. And there's no reliable proof that this disease is contracted in Montana. And you can go to the Department of Health's website, and it's actually the most common of the tick-borne spirochetes that we see in Montana, but they're all acquired in other states. So the question is, the PCR was positive in the knee. Was that repeated at some point? No, and the reason why is that the DNA of these organisms is pretty stable. So DNA is actually incredibly stable. You can extract DNA from fossils. Literally 10,000-year-old mastodon fossils, they've extracted DNA of tuberculosis up. You can extract DNA from mummies. So if we drew fluid and the DNA was positive, what would I do with that information? I wouldn't know, is that the remnants of a dead bacteria that was picked up on a very sensitive test, or is that sign of ongoing infection? Just wouldn't know. I think that it would be reasonable if she was interested in retreatment to consider treating her again with, say, ceftriaxone. But if that didn't work, then I wouldn't recommend continuing to treat or continuing to sample. Now, it's possible you could get reinfected too, which makes it trickier. You treat somebody, it's theoretically maybe a little less likely they'd be infected again, but they could. So if someone continues to be in an area that has it, then you're in this weird situation trying to figure out if they've been reinfected or not. Most people probably not, but it's theoretically possible. So it's a really tricky disease to manage, and there's a lot of information on the internet. Some of it absurdly false, and some of it right on, and it's hard to comb through. It really is, and there are a lot of people that believe that there is a chronic form of this that needs incredibly aggressive treatment, and there's just no data for it. I'm not saying they're entirely wrong, but no one's ever shown that treating with prolonged courses of antibiotics does any good. The other one is tick-borne relapsing fever. This is our 55-year-old guy who lived with Bitterroot, and it's Borrelia hermsii. There are other Borrelia species that do it as well, and they change names from time to time. Borrelia parkeri. There's some old papers I found from the early 1900s where that was found in Deer Lodge, Montana. So the Borrelia parkeri, at least they thought it was, based on the testing they had. Who knows? Maybe it was Hermsii, but you know, these things, these illnesses are out there. We treat him with 14 days of doxycycline, and he got better. He never regained vision in that eye, though. And I touched base with him. Oh, this case was a couple of years ago, and maybe longer than that, and he still never regained vision in that eye. So he's having surgery to see if they can do something to help. And that is interesting because there are only a couple of case reports of that happening, and they were in children with uveitis that severe. The vector of this one is Ornithodorus hermsii, which should have been 2 eyes there. Anyway, it's a soft tick. These things are tiny. They are small enough that it would be very difficult to see one. These ones are the ones, these hard ticks, you walk through the grass, they get on your skin, they crawl on your pant leg, they feed. These ones are associated with rodents. You don't tend to get them walking through the grass. You get them camping, you know, sleeping on the ground for a long period of time where these rodents have been, or sleeping in, you know, in cabins that have not been cleaned well, and they've got rats and mouse nests and chipmunks and so forth have been in there. This one was contracted in Montana.
Most don't attach, right? Unlike the hard ticks, they don't really attach.
These ones will, and they'll feed for a while. Yeah, they don't, you know, they may not tend to burrow in where you're using forceps to try to get them out, but they, you know, they still need to hang on to you and bite your skin. And there's, you know, they need to be on there long enough to get the bacteria from their saliva into your wound. I'm sorry, into your blood. So now on to a different set of paired cases. This one is one of the more fascinating cases I've seen in a pretty remarkable man who I have to say has the most complicated constellation of medical problems I've ever seen in someone so young, and has, despite that, been able to maintain more or less good humor. And he's just a really remarkable guy. I've taken care of him for a multitude of infections for 7 years. This other one is a completely healthy 20-year-old kid. So this gentleman has all these medical issues here. When I say recurrent infections, I mean he's had peritonitis multiple times. He's had multiple bacteremias. He's had skin and soft tissue infections. He's had pneumonias, multiple organisms. He has multiple allergies that at first I thought no one can be allergic to all these things. So we had him see Carol Cady, our immunologist, and she did testing, and I'll be darned, he does. And some of them that he doesn't have allergies to, he has severe adverse side effects to, like tendinopathy with fluoroquinolones, and he really has them. So the options to treat him with infections are limited. In any case, he presented with a cough, low oxygen saturation, fevers, and he was diagnosed with pneumonia in October, and it was a granulomatous pneumonia, which it's a finding on chest X-ray of basically with sort of diffuse opacities, some small little granulomatous ones, some can be calcified if it goes on long enough. And he was initially treated for community-acquired pneumonia with levofloxacin. And I'll go on with his case in a minute while I go to the comparison case. So this is a 20-year-old male, healthy, completely healthy ranch hand, big, tall, strapping young lad. He had fevers, chills, nausea, vomiting. He was sick, right groin swelling, and he was diagnosed with a right groin abscess and treated with a course of doxycycline. They figured, oh, it's got to be Staph aureus. So the exposure history here is really interesting, actually with both of them. So he's a dialysis patient with a dialysis catheter. So I would say once a year or so, we would treat him for line infection. He was very immunosuppressed from his illness as well as he was on steroids. He captured, trained, and flied hawks. He would go climb up rock cliffs, and he would find hawks, and he would capture the babies, and he would raise them and train them, and he would fly them. Like, I guess if you use hawks, you're an ostringer. If you use falcons, you're a falconeer. He explained that to me. So he was flying his hawk in southern Utah, and it caught a rabbit, and it came back and landed on his glove, and they wear these heavy leather gauntlets, and its claw pierced the gauntlet, and he ended up with a little wound, didn't think much of it. Wound got better. Our other one, this young man, he works on a ranch in eastern Montana, and he's around cattle and horses. And on his day off, he was shooting. There are jackrabbits and rabbits everywhere, and he shot a rabbit with 22, and he was going to eat it, but he handled it, and it was sort of a ratty-looking specimen, so he decided not to. And he said he only handled it for a minute, maybe looked at it. Oh, okay, this thing's skinny, and I don't want to eat this, and threw it down and went on his way. So the pertinent findings we have for our 44-year-old with the chronic illness, high white count, fevers, his lungs had, you listen to him, both lung fields, you could hear these sounds we call rails, sign of pneumonia. Chest x-ray with these pulmonary opacities, some are nodular appearing. And he had bilateral pleural effusions, so fluid at the base of the lungs, which is hard to interpret in dialysis patients because depending where they're at in their cycle of dialysis, they may or may not have them. Our young man had swollen right groin nodes initially, and they progressed to suppurative right groin nodes. And this is when I saw him in the office. These huge, angry nodes. And this is after a course of doxycycline. And these got bad enough that I took a scalpel and I incised both of them, and pus just welled out. And we packed him for a couple weeks. And he was very stoic. I used a little bit of lidocaine, and probably not enough. He grimaced, but he didn't flinch. And then later on, his dad told me that it was incredibly painful for him, and I felt bad because I didn't mean to hurt him. I just was trying to drain the dang things. But he was very very stoic about it. Very compliant patient. Did everything we asked. I have no complaints. So our diagnostic test. So our patient with pneumonia, the respiratory and blood cultures were no growth, but this is after empiric Levaquin. He had this huge serologic workup because he had been in the Southwest, including hantavirus. It was all negative. But his tularemia antibody titer was 160. Now, different labs have different reference ranges, and different hospitals, depending on the resources, will have different labs they'll send out. And his was just an antibody titer. We didn't have an IgG or an IgM. It was just a quote antibody. And his was 160, and the reference range is less than 120. And we treated him for a month with a fluoroquinolone, and he got better. And the reason we treated him for a month was we went the shorter course, and he immediately had relapse of symptoms. It was tricky to get blood work in him, even though he was at dialysis, because he was very adverse to having blood draws because he had been poked so many times in his life. So we didn't go on to get paired serology. And while I'd love to know the answer, I'd like to get results. I also, if a patient's better, I can't really justify the cost and the, of drawing blood, as well as the inconvenience and pain to the patient. It's not that big of a deal to get a blood draw, but for him it was, because he'd had a lot of them. So I never really got a set of convalescent titers. I'd be curious to know, but I just couldn't justify doing it, so I didn't. And that happens a lot, not just in my practice. I think in every doctor, their patients are better. You stop doing tests. He'd been on the doxycycline, so even though I got copious pus, it didn't grow anything. But in his case, I got the tularemia IgG and IgM, and they were both sky high. And it made sense clinically. That's what tularemia does for both these patients. So the agent is Francisella tularensis, and it's a gram-negative bacteria. It's an aerobic one. We have this in Montana. It's worldwide, essentially. It's associated with rabbits mostly, but you can get it from ticks and deer flies, and I hate the deer flies. Those things are painful, annoying bite, and now I have another reason to test them. My dad says, though, if it wasn't for deer and horse flies, he's a rancher, cattle rancher, that the horses would just get fat and founder. They never move if you're not riding them, and so the flies keep moving. But in any case, humans usually get it by contact with infected animals. Rabbits are the ones that usually implicated. The story I heard, it was a teaching point, medical school, I'll never forget it, was maybe it was in residency, but in any case, there was a case in Colorado of a young man almost dying of pneumonia from this, and what he had found was he was mowing the lawn on his, for his parents, and he found this dead rabbit, and he thought, being a young teenager, I'm just going to run over this guy several times, and he did. He mowed the hell out of that rabbit, apparently, but He ended up with tularemia. He survived, thank goodness. So don't mow dead rabbits. And it's part of a lot of tick panels. So if you order the knee-jerk tick panel, which we used to be able to do at St. Pat's, and we've changed our labs now. Long story, basically our reference lab has changed. So we can't order this nice tick panel anymore. It's on it because it is included in the list of infections you can get from ticks. So the treatment, severe disease is an aminoglycoside, streptomycin or gentamicin. A lot of these recommendations are based on older studies. It's a hard sell for me to use either one of these drugs in patients. I've seen patients with irreversible hearing loss and balance loss from this. This one's hard to find. This one we'll use these basically in my practice for multiple drug resistance tuberculosis, which thank goodness you almost never see. I haven't seen a case of multi-drug resistant in Montana, and I hope I don't. We use this for endocarditis, occasionally terrible gram-negative infections, or I'll put it in a catheter in someone's bladder for recurrent UTIs. But I try not to use these drugs because they're pretty toxic. So having these be the standard of care always makes me grit my teeth. These are drugs that they're toxic. They require IV or IM administration. And to give somebody IM gentamicin or streptomycin for 10 days, boy, their butt, shoulders, you name it, their soft tissue is going to hurt. But you are allowed for less severe disease. You can use doxycycline or fluoroquinolones. Our first patient got the month of Levaquin. Our second one, he did the IND. After he failed the doxy, he got 14 days of Cipro. Didn't really get better because we hadn't drained it yet. So after I drained it, it hadn't really separated yet. Then he got 14 days of Cipro, and he recovered completely. And his family sent me a really nice card with a picture of him on a horse. So he did great. And I love that follow-up because I assume he did fine. They don't come back to the office. You assume they're better, but I like to know that. The caveat of using fluoroquinolones is they're not FDA approved for tularemia. I will say, though, that many drugs we use, we don't use them for the FDA approved indication. If you look at what the FDA approves the drug for, the list is often fairly short. And sometimes they approve them for things you wonder how they came to that conclusion. But I just have to say that. So if you're going to treat for less severe disease, probably the best way to go is doxy, but you're not wrong to use a fluoroquinolone. And I've treated a handful of cases over the years, not including these ones, that for various reasons I couldn't use doxycycline, usually because photosensitivity in the summer can be a big deal, or nausea, to be honest, is a big one. Because you can always tell your patient, you got tularemia, you got to be treated, wear a sunscreen, wear a hat, etc. They usually will, but if they're throwing it up, it's not going to work. So on to another tick bite. 65-year-old female, she's immunosuppressed with rituximab. She also spends significant time on the East Coast, and she recalls removing a tick. And she's a smart lady. She said, it was a deer tick, and I have no reason to doubt her. She took some erythromycin she had on hand because she's on Rituxan. She has prophylactic antibiotics available. And so this happened in June. And in July, she developed a fever, headaches, and just didn't feel good. She has chronic mild anemia and mild leukopenia, but it worsened. So she went in to see her doc, and they did tick panel, which was negative for Lyme, tularemia, Rocky Mountain spotted fever, and Colorado tick fever. And we did a parasite smear, which we order as a malaria thin smear. It's a test for malaria, but it also picks up the babesiosis. And I got the excited call from the micro lab, hey, come look at this slide. And I got to see it about the third time around because we had to retreat her a couple times. We had some treatment failure. And I wish I would have taken a photo then. I didn't. Then it would have been my personal photo from my own little archive. But without a doubt, there was ring form there. And malaria and babesiosis, looking at a slide, if you don't know the clinical history, can be very difficult to tell apart. But she had never been in an area with malaria. She had this tick. The diagnosis was made. The other thing we did, and the PCRs again are always dicey because, as Dr. Johnson said, do you retap the knee and repeat a PCR? And we generally don't because once it's positive, it may be positive for quite a while. In her case, she failed therapy, and on a smear we couldn't see a parasite. But clinically, she had the same illness, and she was immunosuppressed, and we'd already treated her a couple times, so we did send a PCR on her. And did it not include my slide? Oh, there it goes. The PCR was positive, and this is what they look like. It's Babesia species, and then they speciate down to microtii. And then this I took from the CDC website. Hers wasn't quite this dramatic with every red blood cell having a parasite, but the initial site had a lot, and then later on they'll say less than 1%. You know, I would see one ring form, I'd scroll around for a while, I'd see one more. But they look just like this, and these are from the CDC. So my slides somehow got out of order, I apologize. The main species of babesiosis in the United States is microtii. It's again this black-legged tick that is also called the deer tick. It's usually the nymph that gets you. Again, it's about the size of a poppy seed. A lot of people don't know they were bitten. The treatment is 7 to 10 days of atovaquone and azithromycin or quinine and clindamycin. This is probably a little better tolerated, although that cocktail isn't, you know, people have trouble with them. Either one can be hard to tolerate. This drug is also incredibly expensive. We use it for other things, pneumocystis prophylaxis in patients that can't take dapsone or Bactrim or pentamidine. I can't tell you the headaches and prior authorization drug requests it takes to get this. But you can get it if you try hard enough. And if insurance covers it, great. If not, it's very costly. So she ultimately got better after several rounds of treatment. My partner, David Christensen, did most of the treatments, and Claude Jenner, my other partner, I think he was involved as well. We were all involved in it, but she ultimately got better. I think we've cured it. So now we've got tropical travelers again. And this one is a patient that I saw in the emergency room, and the ED doc called me and he said, I don't know what this guy's got, but you should come see him. And you know, you open the chart because you're super busy, you're on service, and his labs don't look that bad, and you're like, oh, okay. Well, I'm glad they called me. It was an astute, it's the whole sick, not sick. They try to teach in medical school. He was not sick, but he had something that was really weird, and he was a guy that shouldn't have weird things happening to him. And then this is a 50-year-old lady that had traveled to a jungle resort in Costa Rica that came in with a wound on her arm. So I'll walk through the case a little more. This guy's a world traveler. You name the country, he's probably been there as part of his work. And he had been in South Africa, and then to Brazil, and then Grenada, and then the Caribbean, and then Colombia. And he'd been in very dense jungle, spending a lot of time in the bush in the jungle. He said, I was eaten alive by insects, covered in them all the time. He said, just that's how it is. When he was in Colombia, his lips started to swell, and he thought, well, maybe it's just a sunburn. He'd been on the water a lot, the water reflecting off, the sun reflected the water, he ended up with a lot of sunburns. Our 50-year-old female said she didn't ever recall being sick. Oh, and he also said, oh yeah, I had different bugs I'd get while you're out traveling. You'd get diarrhea or what have you, intermittently, mild illnesses. But she didn't recall being sick, didn't recall any insect bites, said she had some itchy areas on her ankles, and that was all she noticed. And 3 or 4 weeks after this, she started noticing these scabs on her forearms. And they just weren't going away, they were getting bigger. So they both had skin lesions, and his got worse. And he saw a lot of docs, and they thought, well, maybe it's herpes simplex, a couple rounds of acyclovir, maybe it's bacterial infection. How about some topicals, some doxy, clindamycin? So he had a lot of people thinking and trying to help him, and they tried a lot of empiric things. And what made, I think, it trickier for a lot of the people to help him was that I don't think he ever went and saw the same provider. He'd go to a now care, or he'd see one doc or another, and it was hard to put the paper trail together. And so I by no means say anyone missed any diagnosis, because everything they did for what he explained to me, his presentation for each individual doc, seems reasonable. But his lip looked like this when I saw him. And that's why when ED doc called me, I think it was Kevin Eichhorn, yeah, he was right. This is, something's not right here. Well, there's a German term called Augenblick, in the blink of an eye. It's when you see something and you know what it is. This for me was Augenblick, and I'll get to it in a second. So this other patient, it's a little harder to know. The skin and lesions were enlarging. She'd gotten some topical antibiotics and then Keflex, and she'd actually gotten a skin biopsy. So this diagnosis was already in the making when she came to see me. So the diagnostic test. This patient, that's classic mucocutaneous leishmaniasis. And it's something that you're in training for ID, you see it. And you've got to know it, because if you don't do anything, it will eventually completely erode and destroy people's face. It will destroy any soft tissue. Doesn't do bone, but it will. There are gruesome pictures. If you Google it, Google image this, and I had a picture, I took it out because of copyright issues. It is a devastating illness, and patients will eventually die of secondary infections, or they'll aspirate, or they'll have airway compromise. It is a very slow moving over months, but it is a horrifying illness. And he Googled it when I said, I think this is leishmaniasis. We're going to do a biopsy. We'll work it out. And once he found the internet, I was called multiple times a day by an understandably upset patient wanting to know what the results were, wanting to know who in the CDC could call to get a result sooner. He wanted answers, and I don't blame him. I did the best I could to reassure him. And anyway, so it was Leishmania panamensis. There are about 20 odd species of leishmaniasis, and there are different subspecies. And they do a PCR, it was positive, and they actually saw the parasites on the smear, and I couldn't get the CDC to give me the slide. But you can see the parasites on smears. So the diagnosis is confirmed by the biopsy. Our other patient, she had the right exposure history, so we were thinking leishmaniasis, but couldn't see the parasites, but the PCR was positive. And then the CDC hangs on to it, and they culture it because there's a lot of interest in this illness recently because it's a devastating illness in the third world, and it's starting to involve returning travelers in a lot of countries with resources. Israel, for example, is putting a lot of effort into diagnosing and treating this illness because, for whatever reason, Israelis like to go to South America, I guess. And there's also leishmaniasis, different species that are in the Middle East, so they've got leishmaniasis there as well. So, in any case, I'm curious. It's the CDC, and it's very difficult to get in touch with someone to get final story down the road, and I probably could if I was more diligent and worked on it, but I just got sidetracked. In any case, so leishmaniasis, there are more than 20 species, Old World, New World species. Cutaneous is the most common, which a female patient had. And they break it down as simple and complex. And there's a sort of an arbitrary definition of simple and complex, and it's basically a table of this makes you simple, this makes you complex. It has to do with number and size of lesions, essentially. Mucocutaneous or mucosal is what our other patient had, and then visceral is the dreaded form that also, it's in your organs, liver and other organs, and it can be fatal. It is interestingly found in dogs, foxhounds, and they have outbreaks in areas that breed these foxhounds. It turns out dogs can spread it sexually to each other. Humans, there's one case report of a sexual transmission of it in all the literature. So it's almost always from an insect vector. This is World Health Organization endemic cases. And I find it fascinating that the United States doesn't report data on this, but apparently it is possible to get it in the southern U.S., apparently. South America is full of it, Central America, and then Middle East and Africa. These countries, I give them a pass on not reporting it. These are third world countries. The data is very hard to get. These countries don't seem to have it. But areas in this belt where you have the vector is where you see it. I've seen in my career 3 cases, and when I talked to the leishmaniasis guru at University of Washington, Dr. Buckner, he said that's pretty good. He said he's seen about a dozen, so I guess my N of 3 is pretty good. So, well, how do we get it? Well, it's this little sandfly, and these things are tiny. They're smaller than a mosquito. It takes a blood meal, and it injects the promastigote into your skin. They're phagocytized by macrophages or other white blood cells, and then they transform into these amastigotes. And then they multiply in cells, and they start destroying tissue, and that's where you can start making a diagnosis. And they are either in your organs or the cutaneous or mucocutaneous, like our patient. Another sandfly comes, bites you, ingests them. The amastigotes go back to a promastigote. They reproduce, and the cycle continues. So it's kind of a nifty organism. And you've got to have these sandflies. And you know, our patient, the world traveler, the young man, covered in insects all the time. Who knows what else? If we would have tested him for Zika and dengue and so forth, I bet we would have found some of them. But so what do you do about it? Interestingly enough, when I first saw that young man, I was by a stroke of luck. When I saw him in ED, this hadn't been published yet. When I had the PCR back, it had. So I had this about a week of thinking, what am I going to do? And my training before, the case I'd treated before when I was a fellow, was we treat with pentavalent antimonials. And our patient had horrible side effects. He had liver injury. He had peripheral neuropathy. It was just a flail to get him through it. But luckily, the treatment guidelines give me a lot of drugs I can use. And this is only a partial list. The reason the list is so big is that it's a terrible disease and people will try anything. And third world countries have limited resources. Well, it looks like I'm going way over. I'll move along quicker. We used amphotericin, liposomal amphotericin B with him. For the mucocutaneous disease, there are no first-line options. They're all called second-line, so I could pick whatever I wanted. Oops, I'll go to the outcomes. He got better. She got better. They both were ultimately cured. Do you want me to do the last case or two, or can it? I guess I'll keep going until people walk out. So another returning traveler, vacation in Belize, was in the jungle, multiple insect bites. While returning home, noted itching red bumps on the skin and failed a course of Keflex. And she felt something was moving. And she was right. This is her arm. And this is what, I still have this in a jar on my desk. This is what we got out of there. This is a human botfly. So myiasis, she had furuncular myiasis, which is a fly larva burrow into the skin. And the treatment is you try to remove the larva intact. If you smash it, you can get a secondary infection. This is what she had, human botfly, but there are screw flies that can cause it too. They're a little bit different life cycle, and then the tumbu fly. Life cycle here is even more fascinating. Our botfly can directly infect a human, and with screw flies, that's what happens. You have a wound. It's just like screw flies in cattle. They go to the wound, they lay their egg, hatches, you get the larva in the wound. Screw flies migrate extensively through tissue, and they can be a big problem. But the human bot lays its egg on a mosquito or a sandfly. It captures it, lays its egg on it, and lets it go. A mosquito or a sandfly bites you, and maybe it gives you leishmaniasis or dengue, and it also drops this egg on you, which hatches. You get a larva. It eventually drops out, pupates in the soil, hatches, and life cycle is complete. This last one, I'll go through pretty quickly. A healthy woman, she was living in the southwestern U.S. This is a case we just had too. I added this almost the last minute. It moved in an unoccupied home, mouse droppings. It was a rural area here in Montana. Skunks, raccoons, bears, deer, you know, kind of like where I'm in Lolo. My dogs smell like skunk all the time. Several days of headaches above the right eye and right eye pressure, and then she acutely had cloudy vision in her right eye. So she went to see her eye doctor and then was referred to Rocky Mountain Eye. Now let me see here. How do I minimize this? Okay. This one right here? This one? There it is. Okay. That's a worm in her eye. That was Dr. Furlong up in my eye. Let me see this image. Pretty fascinating. And some people will actually see floaters. And there's a whole bunch of different. Let's see here. Get out of this one. Different organisms that can do it. So She had ocular larva migrans. See how do I do that? There we go. So there are a lot of different organisms that can do this, and he extracted the worm and put it in formalin, and we were going to figure out what it was, but they're so small, they're, as you can see on that image, they're about the size of an eyelash or smaller. And somehow between the specimen container leaving his office and getting to the pathology lab, couldn't find it. We don't know what happened to it, which is a bummer. Bunch of different organisms can cause it. The CDC looked at the movie though. They're really helpful with that. There's a website you can download images and send them things, and they said it's probably this or this based on what it looked like because they had these parasitologists. The CDC is actually, they're pretty amazing the stuff they can do. The treatment's removal. For sight-threatening disease, antiparasitics and steroids you can use. People have had their eye enucleated for forms of this because what happens is they'll form a granuloma rather than having a parasite moving around, and it looks to some, it can look like retinoblastoma. So there have been cases of people having their eye removed when what they really needed was this and this. So it's something that at least you have to have in the back of your mind. So the likely suspects, we think, the dog heartworm, it's here. You know, dogs have it. It's transmitted by mosquitoes from a dog that has it. And you remove them. There's no clear guidelines for treatment in humans as far as anti-parasitic drugs. Or it could be toxicara, which are dog and cat roundworms. And we get those from ingestion of eggs from contaminated soil. And I forgot to mention, she was a gardener. You know, your cat poops in your garden. You pull out your radish and you eat it. Maybe you've given yourself this. It's probably not these others, Strongyloides stercolis, which is a parasite that only lives in humans, where you walk through the dirt, they burrow through your skin, they spread through your blood to your lungs, migrate up your trachea, you cough them, and then you swallow them. And then they mature in your gut, lay eggs that pass out in your feces. So they can complete their life cycle in a human. And so there was a case we had a while back where a woman said, well, I coughed up a worm, and we caught wind of this, and she was kind of upset. She said people told her she was crazy, and actually she probably wasn't. She probably did cough one up. And the other one is this raccoon parasite. She'd have raccoons around there. And this one, it catches attention because this one, for whatever reason, is very neurotropic. People get meningitis from this. They can die from it. And there's not a lot of good data for treating. Most people don't do very well if they have it. But luckily, it doesn't appear to be that. The life cycles, basically, I went through with the mosquito for the filarial worm. I'm sorry, the Dioflaria. And then for the roundworms, it's, you know, basically life cycle in animals, and if we ingest the stool. My references, and that's it. Question, yes?
I don't know if you can get back to the first slide, but the way I read the very first slide was the very fact that they're being transmitted makes them more virulent. Is that because the stronger ones tend to make that jump, or
So,
did I misread?
so the question is, on my first slide, as part of the definitions, it said there's increased virulence from passing from an animal to a human. And the question is it because the strong survive and they're the ones that are passed on? You know, I don't know. That is a good theory. I think part of it is that some of these, a lot of it, to be honest, is that we're not the host for these. So we have not evolved to be able to combat them very well for a lot of these zoonotic infections. You know, there are animals that can live without being very ill. Say, you know, with certain infections, tularemia, for example, it does kill rabbits, but not as handily as it kills humans. So these animals have evolved over hundreds of thousands of years to be able to exist with these infections where we have not. And I think that's the main thing, is we're just not capable of dealing with them as well. Question?
Is the reason we don't have Lyme, we don't have the right vector?
Correct. The reason we do not have Lyme is we don't, as of yet, we don't seem to have the right vector.
And how do you pronounce the vector's name?
Izodes? Izodes? So one other thing I'll throw in there, I just read in Emerging Infectious Diseases a fascinating article. In Denmark, there's an animal called a golden jackal, and they look like a coyote. For all the world, they look like a coyote. And in Denmark, they found a golden jackal. They're an animal that exists it's sort of in the Caucasus region of Eastern Europe. And they started to find wolves now in Denmark too, where they hadn't had them for 1,000 years. And so they captured this jackal, and they found that it had ticks that were not found before in Denmark on it. And those ticks had Borrelia species that had not been found in Denmark yet. So who knows? We may end up with the right vectors. And you know, with climate change, global warming, whether you believe it or not, or what have you, things are changing. Their migrations patterns are changing. I think it's conceivable that at some point in our life we might have it here. As far as I know, we don't yet. I try to keep an open mind, and if the only reason I caution that we don't have it yet here that we're aware of is that the tests can be falsely positive, and they're easy to misinterpret. And if you send a Lyme antibody and not the Western blot to confirm it, you could give someone a diagnosis of Lyme who it's just a bug in their teeth and their joints ache for another reason, and you treat them with something they don't need and you miss the diagnosis they really have. So that's part of why I talked a little more about Lyme. It's a very, you just really have to think about it. And there are a lot of practitioners who are not, who are treating people extensively with antibiotics that they probably don't need, is I guess what I'm trying to avoid that. I've seen cases of severe C. difficile from patients that had been on 2 years of ceftriaxone or something like that, and not to mention, you know, the cost of these drugs and other problems with them. So.
You seem kind of dismissive about desert fever, like treatable but is that really the experience of the season?
Oh, as far as valley fever, you mean? No, it can be a severe disease. It can. Most patients that get it, most people that get it will get over it without treatment, though. A lot of patients you don't need to treat. They'll come in with an acute febrile illness. It looks like community-acquired pneumonia. They get a Z-Pack or what have you. They get better, and then later on you find out it's valley fever. There are recommendations of who you treat. So patients with severe disease or who are immunosuppressed, absolutely, I treat them. And if patients are sick enough that they feel miserable and they really want treated, I'm not opposed to it. I just talked to them about the pros and cons of 3 to 6 months of fluconazole, because it's not something I can just give them. You know, to really treat valley fever, you've got to treat for a while with fluconazole, which isn't always benign. I mean, it's fine, you know, 150 milligrams of diflucan for a, you know, vaginal yeast infection or a few days for thrush. People tolerate that usually very well. 3 to 6 months of it, it's a different story. I've seen rhabdomyolysis for patients, from patients who are on high-dose statins that were given fluconazole, for example. I've seen pretty significant elevation of LFTs. Brad Picard, one of the surgeons, he asked me to see a patient just last week, and he told me, he said, your antibiotics are making me nervous. These antibiotics kill people. And he's right. I mean, I think it's a numbers game. Sooner or later, I'm going to cause a bad outcome in a patient from one of my antibiotics. It won't be intentional. It'll be out of the best interest of the patient. I'm doing the best with the guidance, the medical guidance I have, to the best of my knowledge, following whatever guidelines I have. Sooner or later, though, someone's going to have a severe adverse side effect. And I've seen some that are pretty bad. I just made a patient neutropenic with vancomycin. Use that stuff all the time. It's reversible, and he's doing fine. But these things are not, they're not the benign medicine that I think the general public thinks they are. I'm waiting on an autopsy result on a patient from, and there were a lot of docs involved. I mean, I just was one part of it. We're trying to figure out, did his bad outcome come from one of our antibiotics? It's possible. We hastened his death. He was chronically ill, had a lot of problems with one of our antibiotics. So I really don't like to use them unless I have to. And people ask me, Doc, what would you do? I would have to be pretty damn sick before I'd take my antibiotic. I mean, I'd really have to be sure I needed it, because I've seen some significant side effects. So any other questions at all? Oh, you're welcome.